Hi everybody, welcome to the Bananas Bites again. The purpose of this thing is to show some anatomical variations of clear clinical significance. That's the idea. Today we're going to talk about the subdural hematoma embolization. We want to focus on the notion of dural supply as a whole. This is a picture from one of the pages on neuroangio. Basically the point of this thing is that the MMA is not the sole supply of the dura. There's lots and lots of other things out there, and it's important to know them. So here's a very nice example of an isodense subdural. You can see a better one, but it's a pretty good one. Here's one more. That's a few days later, actually, after he got transferred to us. And that's the coronal. We did a CTA, so whatever, it's a CTA. Anyway, this is after some drainage, and now we're gonna follow it up with an MMA embolization. There's the frontal, still some mass effect there, huh? There's the ECA, and here's the lateral of the ECA. We'll come back to that picture a bit later. So standard thing, microcatheter and the MMA. You get a picture. Look at this beautiful membrane enhancement, right? All of this hyperemia of the membranes. See that most often like this, right? Very nice example. That's a stereo, a cross-eye stereo, for those of you that like this kind of thing. Okay, so what do? We go into the petrosquamosal branch. We go into it far enough that we're kind of at the table of the skull, so we're past any facial nerve business. We inject some particles in this particular case. After that, we go to the frontoparietal branch. And so here's some particle embolization, right? You see that typical small particle embolization with contrastasis in the embolized area. And so here's the walk. This is the beginning. It's like a tree with a bunch of leaves. So at first we inject, we see the whole entire thing. Now as we march back, we see how the leaves kind of start falling down. We're pruning the tree, walking our way more proximal. Here's again. So now we basically have a situation where you have the trunk and the branches, but the leaves have been lost. Why? Because they're saturated with embolic material. And you see that white, you see those white areas? That's where the contrast is leaching out a bit from the already embolized parenchyma. And we top it off with a little coil. So here's the post. Now you see the frontal view. There's some kind of funny hyperemia over there again. Now that's the view here. Now what's going on here? Looks like there's still some dura present. Now if you go back and you re-look at the beginning of this, you'll see that this area was not seen on the MMA injection. And so there's a little piece that was missing over the parietal lobe. And now you see that piece coming in. Now where that's coming from, you can see that's coming from the occipital artery in this case, right? So should we go for it or not? Well, we don't really know at this point, but why not try? So I think probably a decent idea to go for it. I don't think the risk is particularly high, but we want to be effective. What do? We take this microcatheter. That's the headway duo, one of our favorites. And you go up and you get this picture. We're still fairly proximal, but even from here, you see that there is flow. We don't have a flow arrest situation. We can put some small particles even here. I don't think the skin is going to mind too much. We use the contour particles. These particles are pretty forgiving, but we want to see maybe a little bit more closer. We get this dyna CT and whatever, this rotation will be reconstructed. Why? Because we like it. We want to show this. So here's a picture. That's the occipital. Take away some bone. You start to see that transosseous branch, right? Take away a little bit more, and now you see what's going on, right? It's a fairly major supply. So again, the dura is a variable thing like anything else. The supply comes from other places sometimes. And so here's some stereo pairs. You can pause on that, cross your eyes. It's pretty nice. Look at this. So the dura makes its way way over there. And that's with the aid of a hybrid 007 wire. That combination for going distal is a pretty good one. So we are basically at the ostium of this transosseous branch. If anybody thinks we're going to knock off some skin, well, now we won't. Not that we care too much about it in the first place with the particles we use, but this is better. And still we don't have flow red. So here we go, we knocked off some dura. That, and this is the final. We put a coil up there too. So here's the right occipital artery at the end. All these images are reversed. We have a new PACS in one of our hospitals. It does a lot of things in reverse, to be honest. This is one of them. So it's a little bit backwards, at least for Siemens. So anyway, here's the occipital post. Looks pretty decent. That's the global external. And here again, this is the common post, right? Common post lateral. And of course, we don't mention at the beginning, but always pay attention. You see the ophthalmic artery coming from the ICA. That's the number 1 through number 10 things to have in your mind whenever you're embolizing the MMA. Just look at that place, 3, 4, 10 times. Not one time too many. And so that's the idea. A little bit distal catheter placement, safety first, and pay attention to those alternative sources. We have another case where the contralateral MMA happened to be going to the area of supply. Some other things too, besides the usual like recurrent meningeals. The point is, the dura, nothing is written in stone. It's not just about the MMA. Could be some other things to worry about too. Said that, take a look at this, look at the page. Thank you for your attention.